Today we will be discussing the basic biology of SARS coronavirus 2, the virus that causes the disease COVID-19. We have three learning objectives in this presentation. First, what are the basic biological features of the virus, including how it replicates and how it causes disease? Second, how does the virus spread between people, and what interventions can limit spread? Third, what are the most promising drugs in clinical trials and preclinical development? We'll start off by defining two basic terms. First is the name of the new coronavirus isolated in Wuhan, China in 2019. This is SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. This name is officially designated by the International Committee on the Taxonomy of Viruses and is based on a high degree of homology between the new virus and the one that caused SARS in 2002 to 2003. In fact, the viruses are 80% identical overall, with specific proteins having 96% identity. You may read of 2019 nCoV, a provisional name, or HCoV 2019, another proposed name, but these names have not gained traction in the research community. The second definition is the name of the disease itself, which you have certainly heard of, COVID-19. This stands for Coronavirus Disease 2019. This name, selected by the World Health Organization, is unusual among disease names in not including any disease features, but instead including a date. In practice, the diagnosis of COVID-19 is given to people who have a positive lab test for SARS-CoV-2, regardless of clinical presentation or clinical status. The general public is also more aware of COVID-19 than SARS-CoV-2. Thus, you may hear the disease name being used in place of the virus name. SARS-CoV-2 belongs to a large family of viruses called coronaviruses. These are positive strand RNA viruses with large genomes of more than 27,000 nucleotides. Within the coronavirus family, two groups, alpha and beta coronaviruses, are well known to cause human disease. For example, the coronaviruses NL63-229E and OC43 cause 10 to 30% of cases of the common cold. An unusual feature of the coronaviruses is that they can easily hop between mammalian species. For example, closely related coronaviruses can be found in cows, camels, civets, rodents, bats, and humans. Middle East Respiratory Syndrome, or MERS, and SARS were caused by coronaviruses from camels and civets, which had likely evolved earlier from bat viruses. A virus with greater than 95% identity to SARS coronavirus 2 has been isolated from bats in China, but the immediate host animal prior to humans has not yet been identified. We will now discuss the SARS-CoV-2 life cycle, calling special attention to 5 steps. In step 1, SARS-CoV-2 binds to host cells, with the viral spike protein engaging the cell surface protein angiotensin converting enzyme 2, or ACE2. In step 2, the spike protein is cleaved by a host protease to activate membrane fusion. This can be either TMPRSS2, which resides on the cell surface, or cathepsin L, which resides in endosomes. After spike activation and membrane fusion, the single positive strand of viral RNA is released into the host cytosol. There, in step 3, it is translated by host ribosomes into large polyproteins. These are immediately proteolized into smaller pieces by the activity of 2 embedded proteases. The pieces then assemble to form the RNA-dependent RNA polymerase, or replicase. In step 4, the replicase creates full-length negative strand genomes as templates and full-length positive strand genomes for packaging. The replicase also transcribes what are called subgenomic RNAs that encode the nucleocapsid protein and the transmembrane spike matrix and envelope proteins. The nucleocapsid protein wraps up the new full-length RNA genomes, while the transmembrane proteins are translated at the ER for transport into the Golgi and exocytic vesicles. In a final step, transmembrane proteins assemble around the nucleocapsids to pinch them off into new virions within the exocytic vesicles. These are then released from the cell upon exocytosis. The host receptor for SARS-CoV-2, ACE2, is highly expressed on epithelial surfaces in the respiratory and GI tracts, where cells also express cathepsin L. Thus, the virus can enter and spread throughout respiratory and digestive systems. Vascular endothelial cells also express ACE2, but lack expression of cathepsin L, which may explain the inability of SARS-CoV-1 and presumably of SARS-CoV-2 to replicate in vascular endothelium. Once SARS-CoV-2 has gained entry into the body, COVID-19 pathogenesis progresses through 3 phases. The first phase is a lengthy incubation period of about 1 week. Importantly, it is now believed that people can start shedding the virus near the end of the incubation period, 1 to 2 days before the emergence of symptoms. The incubation period is followed by the second symptomatic phase. Here, the ability of the virus to infect the respiratory and digestive systems explains the flu-like symptoms of fever, cough, fatigue, sore throat, aches, and shortness of breath, as well as GI symptoms such as diarrhea. Anosmia, or the inability to smell and taste, is also a commonly reported symptom. In most infected people, estimated as 90 to 95% of all infections, the disease is self-limiting, and indeed 25 to 50% of people may not notice symptoms at all. About 5 to 10% of all SARS-CoV-2 infections progress to a third phase of severe disease, presenting with widespread bilateral pneumonia and oxygen desaturation, and requiring supplemental oxygen about 2 weeks after infection. About 2.5% of patients progress to acute respiratory distress syndrome, or ARDS, marked by alveolar breakdown and pulmonary edema with immune cell infiltrates, and requiring mechanical ventilation. In some cases, multi-organ dysfunction syndrome can occur as well, although it is unclear if this is due to disseminated viral replication or systemic cytokine release. Regardless, the release of pro-inflammatory cytokines such as IL-6 is believed to contribute to the pathology of both ARDS and multi-organ dysfunction. It is useful to note that the pathophysiology of COVID-19 is essentially identical to that of SARS, which is as expected from the similarity of the viruses. The main difference is that a smaller percentage of COVID-19 cases progress to severe disease. COVID-19 demonstrates a steep dependence of mortality on age, with approximately 1% mortality in the overall population, rising to 4% above age 70 and 8% above age 80. In contrast, the mortality of SARS is roughly 10% across all ages and 50% above age 70, so SARS is roughly 10 times more lethal than COVID-19. What underlies this age dependency of clinical outcomes? B and T cell responses to viral infections diminish with age, and this is believed to underlie the increased susceptibility of older patients to respiratory viruses such as flu and SARS. Indeed, in controlled tests, non-human primates infected with SARS virus showed decreased lymphocyte responses with age. This weakening of adaptive immunity in older patients may allow SARS-CoV-2 to continue replicating in lungs after the first 2 weeks, leading to the more severe third phase of the disease. We will now turn to how SARS-CoV-2 infections can be prevented. Knowing SARS-CoV-2 transmission routes and the physical characteristics of the virus allows us to understand how to take effective countermeasures. SARS-CoV-2, like SARS-CoV-1, is spread through 2 main routes. The first route is the direct route, in which respiratory droplets are generated by an infected person and inhaled by a healthy person. The second route is an indirect route, in which an infected person touches a common object or emits respiratory droplets onto the common object. A healthy person touching the object, and then her nose or mouth, can then become infected. Effective countermeasures to prevent SARS-CoV-2 infection in a healthcare setting or in public settings need to take into account both transmission routes. Face coverings are the primary method for breaking the direct transmission route. Hand sanitation immediately prior to and after touching potential fomites are the primary method for breaking the indirect transmission route, although masks may play a small role as well in reducing the amount of respiratory droplets emitted by infected people. There is some confusion about the utility of face masks in reducing SARS-CoV-2 transmission, so we will cover this briefly. Face masks can refer to both surgical masks and cup-shaped N95 respirators. Published guidance such as this document from the CDC states that surgical masks provide some protection against large droplets and also prevent emissions from the wearer, but does not provide a quote-unquote reliable level of protection. On the other hand, N95 respirators are rated to block 95% of aerosols of 200 nanometer size or larger. It may be useful to keep in mind that some people will mean only N95 respirators when they talk about personal protective equipment, whereas others will consider both types of masks as PPE. Both surgical masks and N95 respirators use a polypropylene mesh as a filter layer. You will hear of this referred to as the melt-blown layer. It catches most virus particles by physical block and by electrostatic attraction, while allowing through air. The main difference between surgical masks and respirators is that surgical masks are loose-fitting, so air can still be inhaled around the mask. This is why they are believed to be less effective than N95 respirators at blocking viruses. However, we can still get an idea of their effectiveness for blocking SARS-CoV-2 from multiple studies of flu transmission that have been carried out, as SARS-CoV-2 is similar in size to influenza virus. Indeed, 3 controlled trials in Canada and Australia show that N95 respirators appeared slightly more effective than surgical masks in preventing acquisition of respiratory disease by healthcare workers, but the differences were within statistical error. In addition, a study in Australia found the wearing of surgical masks by adults cut the risk of acquiring flu from their children by 60 to 80%. Thus, the available evidence suggests that surgical masks do provide some protection, and their use by the general public to reduce the risk of transmission via occasional encounters is probably merited. However, in high-exposure environments such as healthcare settings, using N95 respirators for maximal protection would certainly be preferred. We now turn our attention to how to limit indirect transmission via commonly touched surfaces or fomites. First of all, how long does SARS-CoV-2 survive on surfaces? This has been investigated in 2 studies, one in the New England Journal of Medicine and the other in The Lancet. Results from the New England Journal of Medicine study are shown here. Survival of virus at room temperature drops 10-fold for each 8 hours on cardboard, 12 hours on steel, or 24 hours on plastic. For 100-fold drops, you would need to roughly double these times. This study used 3,500 infectious virions as the beginning amount, which is similar to the number of infectious virions that can be emitted in one cough by a highly infected patient. Starting from this amount, the number of infectious virions become undetectable at 2 hours on cardboard and steel and 4 days on plastic. This tells us that indeed we should either sanitize cardboard, steel, or plastic objects that have been touched by others, or wait a few days before handling them. How about the influence of temperature and sunlight on SARS-CoV-2 survival? Temperature has been examined in the Lancet paper. In liquid, SARS-CoV-2 is stable at 4 degrees Celsius, that is in a refrigerator, for over a week, but there is a 1 log, that is 10-fold, reduction in 3 days at room temperature, and in 12 hours at 37 degrees Celsius, that is body temperature. At 56 degrees Celsius, 1 log reduction occurs in 5 minutes, and at 70 degrees Celsius, it occurs in 1 minute. SARS-CoV-2 is also likely sensitive to UV. Based on work with other coronaviruses, 90% is estimated to be killed by the amount of UV in 3 hours of direct sunlight. Finally, how do we actively kill SARS-CoV-2, for example on surfaces? SARS-CoV-2 is an envelope virus, that is, it is enclosed in a plasma membrane. The plasma membrane can be directly dissolved by surfactants, that is, detergents, such as in soap, shampoo, and various cleaning agents. It can also be directly dissolved by alcohol, above 60% in concentration. The proteins and phospholipids can also be destroyed by disinfecting chemicals, such as bleach, hydrogen peroxide, or quaternary amines. In the last part of this presentation, we will discuss antiviral therapeutics. As of early April 2020, there is no proven therapy for SARS-CoV-2 and COVID-19, but there are several drugs that may have antiviral activity based on preclinical work and preliminary clinical results. Let's return to the virus replication cycle. As we discussed before, 4 important steps are binding of the spike protein to ACE2, cleavage of spike protein by host proteases, proteolysis of the viral polyprotein by viral proteases, and RNA replication. Each of these steps can be blocked by drugs in viral culture experiments. The first example we will discuss is Chemostat. Chemostat is a drug approved in Japan for certain cases of pancreatitis. Chemostat inhibits TMPRSS2, one of 2 host proteases that can activate the viral spike protein for fusion. It has been found that Chemostat blocks entry of SARS-CoV-2 into cultured cells at low micromolar concentrations, which can be considered medium in potency. Interestingly, Chemostat prevents death from the closely related SARS-CoV-1 in mice. Chemostat is currently in trials in Denmark for COVID-19. The second example is chloroquine, or the closely related hydroxychloroquine. These drugs are approved worldwide for malaria prevention and as immunosuppressants. They inhibit endosome acidification and were found to block replication of SARS-CoV-2 in cells at low micromolar concentrations in culture, reproducing earlier observations with SARS-CoV-1. Thus, it is possible that blocking endosome acidification blocks virus entry into cells. However, these drugs also have anti-inflammatory activities, which can be helpful in preventing late complications such as ARDS. In one 62-patient randomized controlled trial in China, hydroxychloroquine was found to prevent progression of severe disease, but all patients in both arms recovered, so its ability to prevent deaths is still unclear. These drugs are in 23 trials around the world for COVID-19. The next step in the virus life cycle is translation of the viral polypeptide and processing by embedded viral proteases. The combination of HIV protease inhibitors lopinavir and ritonavir have been proposed to be able to inhibit one of the SARS-CoV-2 proteases. This combination was studied in a randomized controlled trial of about 200 COVID-19 patients in China, but found to have no benefit. However, it is still being studied in 8 trials around the world. The following step in the virus life cycle is RNA replication. One drug that appears effective at blocking this step is favipiravir. This is a broad-spectrum inhibitor of RNA replicases that is approved in Japan for influenza. It functions as a prodrug that is metabolized into a nucleoside analog and then incorporated into viral RNA to cause mistakes in replication. Favipiravir was found to inhibit SARS-CoV-2 replication in culture at concentrations in the tens of micromolar, but it can reach concentrations of hundreds of micromolar in the body after oral dosing. Finally, we turn our attention to remdesivir. Remdesivir is not yet approved for any indication, but it recently completed a phase 3 clinical trial for Ebola with moderate success and an acceptable safety profile. Like favipiravir, remdesivir is a nucleoside prodrug and shows broad-spectrum activity against many viral replicases. It inhibits SARS-CoV-2 replication in culture at low micromolar concentrations. It blocks SARS-CoV-1 replication in mice and MERS pathology in monkeys, and appears to be the best in terms of efficacy of known drugs against coronavirus disease in primates. Remdesivir is in multiple clinical trials worldwide, with results from China expected in mid-April 2020. Aside from blocking viral replication directly, drugs that modulate the immune system may also be useful for treating life-threatening complications of disease. ARDS and multi-organ failure seen in COVID-19 may result from an excessive inflammatory response, that is, cytokine storm. There is anecdotal evidence that clinically approved monoclonal antibody inhibitors of IL-6 may be beneficial in improving pulmonary function. These are being tested in a randomized controlled trial in Denmark. This brings us to the end of our presentation. I will now summarize the main points. First, the virus that causes COVID-19, SARS-CoV-2, is very similar to the SARS virus, SARS-CoV-1. Thus, we can learn a lot about COVID-19 by studying SARS. Second, disease outcomes in COVID-19 range from asymptomatic to flu-like to fatal, and pre-symptomatic transmission is possible. Third, COVID-19 transmission occurs through 2 routes, directly via inhalation, and also indirectly via contact. Fourth, as an envelope virus, SARS-CoV-2 is environmentally sensitive and directly disrupted by surfactants and solvents. Fifth, the virus life cycle and the host inflammatory response reveal possible targets for drug therapy. And finally, no drugs have proven beneficial for COVID-19 yet, but there are several promising candidates, some of which are available for off-label or compassionate use. Thank you very much for your attention.